So I want to introduce Dr. David Hsieh, Associate Professor, Department of Internal Medicine, Division of Hematology and Oncology at UT Southwestern. He specializes in hepatocellular carcinoma, cholangiocarcinoma, and gallbladder cancers. His research also explores translational studies of treatment biomarkers, mechanisms of drug resistance, and ensuring equity in cancer care. He earned his medical degree from the University of Arizona College of Medicine, completed his internal medicine residency at Mount Auburn Hospital, and fellowship trainings in hematology oncology at UT Southwestern. Everyone, please welcome Dr. Hsieh to the stage. Thank you.
Okay, thanks for having me. I'm going to go through some terms that we're going to be using, and this might be a background for a lot of people, so just bear with me. But I introduced myself as a medical oncologist, which means is that I treat cancer specifically with medications. So that comes up to our first word, what does systemic mean? So we went through the different definitions in terms of we have surgery and these other local therapies that are treating cancers where we can see them. So the problem with cancer is that sometimes they are growing in areas that we can't see yet, or they have essentially spread to areas that are just hard to quantify on our imaging, like our CTs or MRIs. And that's what systemic therapies are for, is that they can treat the cancers not just where we see them, which can sometimes be extensive already, but also where we don't see it yet. So these generally refer to medications because they are disseminate, whether we take them orally or through our veins, is that they disseminate throughout the body, essentially anywhere there's fluid that can flow. Chemotherapy, now this is a term I think everybody's heard of before, and generally though, chemotherapy refers to chemical compounds that are used for cancer care, and in general, it's referring to our sort of, I would say, our cytotoxics. So essentially these are toxins that kills things that grow fast, which essentially is cancer. But in liver cancer care, those treatments are not very effective. So even though they're very effective for colon cancer, breast cancers, lung cancers, a lot of different cancers, they just don't work patients don't live longer necessarily when we use them in liver cancers. So the field's moved on. And so that's what we're going to talk about, give some background on other classes of medications. So the first class is what we call immunotherapies. These are medications that modulate or harness our own body's immune system to try to fight the cancer. And then there's targeted therapies, which are essentially also generally small molecules. So these chemicals that were designed to work more selectively, specifically targeting vulnerabilities that cancer cells need, but are less drivers of other biological processes in the body. So just a quick background, because to understand how our treatments work, we have to understand how cancer develops. So cancer is a multi-step process. Nobody, wakes up one morning and was completely fine the other day and started to have all this cancer. Obviously, that can be sometimes how patients present. But these cancers take time to develop. And we think that in almost every cancer type for most patients, it's a very gradual process. We're not talking about months, many months. We're usually actually talking about sort of a span of, again, many months to even years. And it's because cancer develops from mutations in the DNA. Everything in all the cells in our body, all the individual components of our bodies, including the cells in our skin, to the cells in our colon, to the cells in our liver, all have generally the same DNA that we're born with. But guess what? As we get older, that DNA can get altered. And that's what we call mutations. And these mutations essentially cause defects in the normal functions of those cells. And the reason I sort of describe this as sort of the DNA is sort of our reading instructions to tell our body how to behave and what to do. Our skin cells read one chapter for the skin. Our liver cells read one chapter for the liver. And if there's a sentence in there that goes from do not grow, stop growing, and all of a sudden you take away the word not, like a mutation could, then the DNA is telling the cell, grow, right? And so that's what it is. So essentially, cancer is a process of these mutations causing cells to tell them to continue to grow and eventually to become more invasive, to spread, and to basically damage the body. So in addition to this process of cells growing uncontrollably and being migrating and being invasive, they also have to evolve to avoid the immune system. So the immune system is constantly in motion, even when we're feeling well. And it's because our bodies cannot sustain itself because everything around us is a hostile environment, right? Everything we touch, anything we put in our food is always a source of something that can overwhelm our body and infect it in some way. So the immune system's always in motion. And it also has this, it's always in war with potential cancers that could develop. And the problem, though, is that there are many ways that cancers can avoid the immune system. And this sort of highlights sort of a life cycle in terms of how the immune system, when it's working as it's supposed to against cancers. So essentially the cancer cells, there's a way that all the cells in our body are recognized by the immune system to say that it is normal, that it's not something that they need to mess with, right? If our bodies are healthy and every cell in our body is doing what it should be, then the immune system should leave it alone. But there's also a way, if something becomes abnormal in that cell, for example, it has a mutation, like those cells will start looking different. You could put them under a microscope and they'll actually look different already. And our immune system, believe it or not, actually has ways of recognizing those abnormal cells. And there's a series of steps of different immune cells talking to each other that eventually leads to certain dedicated immune cells of attacking and eating those cancers, and then training other immune cells in the body to find that cancer and kill it off. But the problem is that cancer many of the cancers that do develop have already learned or evolved to avoid the immune system. So the trick, is, how can we harness the immune system's sort of these innate functions that it has to work better, right? So it may work well in previously or in some settings, but how do we make it work better? And that's actually how immunotherapies emerged. Was I sort of describe these immunotherapies as hitting on the switch. So your immune system is like a series of switches, but it's more like a rheostat. It's more fine tuning. But if we think of it as switches, there are many times where our immune system needs to be on to fight off infections, to fight off cancer. But there are also many times where it needs to turn off, right? Otherwise, your body's in a constant state of inflammation and it's being revved up for no reason. And cancers can turn off some of the switches that are normally supposed to be turned on to eradicate the cancer. So it's almost the cancer's immune defense against the immune system. And these immunotherapy drugs that are currently used can turn back on certain switches that the cancer has turned off. Okay. And so specific ones that are already in use include what we call PD-L1 inhibitors or CTLA-4 inhibitors. And this is just a sort of a curve a diagram that I drew from one of the trials that was testing immunotherapies and showing that they were more effective than some of our older treatments. And I want to describe this because I think it's very meaningful to understand this is what data is and this is what it tells us. So if you look on this line, this is actually what we call the y-axis, and it basically tells us the proportion of patients that are alive, okay? And on this side of the diagram, you see it's labeled months. So this is basically time that's increasing from 0 to 30 months. You see these two lines, and essentially there's two lines because one line represents all the patients on this trial that was treated with immunotherapy called atezolizumab bevacizumab. It's just one of the immunotherapies that is used. Thankfully, right now, we actually have multiple, but that's just the one that I cherry-picked. The second line is a drug called sorafenib, which is one of our earliest drugs for liver cancers, but it's not an immunotherapy. But what you can see is that these two lines are not overlapping. And ideally, if we had a treatment that was 100% effective, all the patients that were treated at 0 months should be alive at 100%. That makes sense. But if we had a perfectly good drug, there would be the line of patients would be all up here over time, right? Because if it was worked perfectly, 100% of patients at 30 months would be alive. So no, we don't have any drugs that work perfectly, and we definitely don't have it for liver cancer at this time. But what you can see is that the line for liver cancer is closer to this corner than the other line. So that tells us is that patients treated with immunotherapy are living longer. And if you get to the very end of this, towards, again, 30 months, you can see that, or towards, I would say, the 20 months is more clear. You can see that the difference is pretty meaningful. It's a difference of almost 10% of patients that are able to live that long compared to our older drugs. So immunotherapy is not, I would say it was a breakthrough in the sense that, we had a substantial improvement in how patients now living longer. It was also a big advantage that immunotherapies in general are one of our best tolerated treatments. So these are drugs that many of my patients still maintain their quality of life. They're still, some folks are working, hanging out with their friends and family, doing stuff around the house. And so, this curve stops at 30, but we even have patients that have been on immunotherapies now for liver cancers for years, many years. And that was historically very rare. Now we're going to switch gears to talk about what targeted therapies are. As I mentioned, that was another type of medication that we use to treat liver cancers. And generally, we use targeted therapies now for patients specifically if they haven't responded as well to immunotherapies. The way that the current generation of targeted therapies that we're using now for liver cancers focus on a specific vulnerability of the cancer, which is called vascular endothelial growth factor. And this vulnerability comes from the fact that cancers are fast growing. They need blood as well to survive. They need oxygen and nutrients. So cancers have evolved a way to basically secrete factors, little signals, to tell the rest of the body, give me more blood, and to actually form new blood vessels towards it. And that molecule, that signal that I'm talking about is actually this vascular endothelial growth factor, or VEGF for short. And the way that our targeted therapies currently work is by actually stopping that signaling from happening. So it actually starts, the goal is to try to starve off the blood supply to these tumors. There's other mechanisms that have been proposed for how these drugs can work, but this is sort of the fundamental. And again, patients can have shrinkage of their tumors after these drugs. In some cases, they can be quite durable. These are drugs, though, that can also cause other particular side effects. So there's some cons as well. But, in some patients, they can work reasonably well. Oncology as a field has really revolutionized over the last 10 years. We've had more FDA approvals for drugs in the last 5 years than we've had in the last 15 years. So things are moving fast, and there are, liver cancer mutations. So I brought up the whole story about mutations because those mutations happen in very specific places of the DNA called genes. And depending on where those mutations occur, there might be other types of targeted therapies that can be used for patients with those gene mutations. They're not very prevalent in liver cancer, but nonetheless, you can find them. And so even since 2018, we've had actually a series of these other drugs that are targeted therapies but target other specific gene alterations or vulnerabilities of the cancer cells. So it's sort of an exciting time because we're actually, one was approved just recently last year. And I'm going to close up by, we talked about our standard treatments, the existing standard of care for treatment of liver cancers using medications. But how did we get there, right? So, one thing that I think is often very confusing is that people think of clinical studies and clinical trials as being entirely experimental. And that's 100% correct. Trials are by definition, we're trying to learn and we're studying, and every patient matters. But what I would say, I think there's a bit of misunderstanding is that these are inherently more risky or potentially less effective than standard treatments. And the opposite is true. Every existing drug in modern oncology must have been studied in a trial to even have been approved by the FDA. But approval is not in a sense, the approval does not mean too much because some of our drugs that are approved only extended life by 1 to 2 months. It's improvement enough by some standard, but it may not be meaningful to every patient in this room or every family member in the room. So that's the reason why I bring up the point about clinical trials specifically is because many of our trials are not, trials are not all the same. They have different risks, different designs. The trials, for example, when there is already an established standard treatment, let's just say immunotherapies, as I mentioned, is our preferred treatment. Well, our trials that are for patients who have never been treated with immunotherapies and have liver cancers are generally trials that are testing immunotherapies in addition with drugs to try to make them work better, okay, or potentially more safe. Trials that are, for example, what we call phase 1 trials that are testing new molecules for the first time in the first dozen patients, those trials are very different. They are more at risk, you consider, because we're studying them for the first time, but we would not use them. Those are not appropriate for patients who would have other opportunities for standard treatments. Does that make sense? So that's something that I would say should always be discussed with an oncologist is, hey, is there ever a trial opportunity for me? Because it might actually be the next best thing, right? And you'd be the first, keep it one of the first ones to have it. In fact, one of the patients that I mentioned that we've treated for, she's now 7-8 years, around 7-8 years out now. She was one of the first patients in the United States enrolled on one of the first immunotherapy studies that was done. So the drug was approved after she had already started this treatment, after she had responded to her treatment, and is still doing very well. That's it.